So my name's Jordan Fearman. I'm an interventional physiatrist here at OCR. I started in December. I was a couple years out of fellowship. I was practicing in Denver previous to this. And so my primary focus is spine. I also do EMGs and general musculoskeletal care. But today we're going to be talking about spine interventions and indications for different procedures. So these are procedures we're going to be talking about today. So all these are non-operative procedures, of course, but patients generally will have gone through physical therapy and other conservative measures such as medication management prior to getting one of these interventions, or they're a non-surgical candidate, so they're sent to me to try to attempt one of these interventions instead. To hopefully save them from undergoing surgery. So indications, for a radiculopathy, number of causes of that, including herniated disc, spondylolisthesis, spinal stenosis. Other indications for certain procedures would be facet arthropathy or arthritis, sacroiliac joint dysfunction, etc. So first off here, we can see, so this would be a cause of radiculopathy, of course. We can see a nice little disc herniation there in the lumbar spine. So this is the L4 and L5 level, and right in between them you can see that nice disc, which is bulging back towards the spinal cord and nerves. Same thing in the cervical spine here. So this is at C5 and 6. So here's C5, here's C6, and you can see that nice disc herniation there, impinging on the cord and nerves. So the disc herniation here would likely be causing sciatic type pain. And then in the neck, likely radicular pain down the upper extremity, either one, depending on which side the herniation is going to. And here we see a CT image on the left side. So what we're looking at here is facet arthropathy or arthritis. So common cause of axial back pain strictly, usually non-radicular. Occasionally you'll get some radiation from these joints into the hips or groin area is a common complaint. But you can see a lot of sclerosis here. All that hyper-intense signal is basically all arthritis, essentially, in those joints. In the cross-sectional view, you can see the same thing. And then you can definitely see the hypertrophy of this joint here on the right side compared to the left side as far as the arthritis goes there. In the right pane here, we have MRI view, again, an axial or cross-sectional view. And we can see actually some hyper-intense signal in the facet joint itself, and that's actually a facet joint effusion, which if you go into the joint and do an injection, sometimes what you'll see is fluid actually coming back through the needle as basically an aspiration of that joint, and then you would inject the steroid following that. So that's pretty common as well, which you'll see on MRI. This is a cross-sectional view CT of the sacroiliac joint. So left side is actually here, right side here. You can see that sclerosis at the bottom of the joint right there on the right, indicating quite a bit of arthritis in the sacroiliac or SI joints. Common cause of buttock pain, axial back pain below the belt line. So for these procedures, you'll need several different types of materials. So first off, you'll need a needle. All these needles are beveled. There's a stylet which inserts into the needle, into the cannula, and that stylet will stay in there until you're ready to pull it out. So during the whole procedure, as you're guiding the needle, that stylet will stay in there, and then you take it out once you're ready to inject. There's several types of needles. They range from 22 gauge to 25 gauge as far as a standard needle goes, 3.5 to 7 inches depending on the depth that you'll need. And then there's the TUI needle, which is used for interlaminar procedures, and that comes in 16 or 18 gauge and 3.5 to 5 inches, depending on the depth, once again, you'll need. So this is the TUI needle here on the right, and then this is our standard needle. Looks like a 25 gauge here. So again, the stylet seals the cannula during any advancement of the needle, should always remain in place during any forward movement of the needle. So medications that we'll be using typically are lidocaine or bupivacaine. Lidocaine typically for the skin. Bupivacaine will usually be mixed with steroid and injected into joint, either the facet joints or sacroiliac joint, for example. Steroids, so two different kinds that are used. Soluble, which is your dexamethasone, and then your non-soluble or crystalline are Kenalog, triamcinolone, methylprednisolone, and betamethasone. So typically with these, I'm using dexamethasone for epidural injections. The reason being because it's soluble. So if you do encounter a vessel, which we'll talk about later on, and it becomes vascular in the lumbar spine, that prevents any sort of crystallization, which could cause a spinal cord infarct if a non-soluble corticosteroid enters the spinal cord. And in the cervical spine, same thing, can even cause a stroke if it gets into a vertebral artery. So you want to use dexamethasone. Generally is used for anything epidural, and then for anything joint related, generally you can use the crystallines where you won't encounter any vessels and have any risk of those complications. Two forms of contrast use iodinated versus gadolinium base. So iodinated, again, I use in non-epidural cases, or epidural cases, sorry, because the risk of there's risk of gadolinium seeding into the intrathecal space and spinal cord, as well as the brain, even using gadolinium in an epidural injection if it's vascular. Leads to encephalopathy, stroke, all kinds of complications you don't want to risk. Protective equipment, important. So all these are fluoroscopically guided procedures. So you want to make sure you're wearing your lead apron, your thyroid shield as well, lead glasses, as well as it's all sterile, of course. So you have your sterile gloves, your hat. I wear a mask as well. You don't necessarily need a gown. Some people choose to wear gowns as well. So first step in the procedure is positioning of the patient. For all these procedures, patients are going to be lying on their stomach. There is sedation involved for most providers, some, not all, but the ones that are commonly used are medalazam or Versed and fentanyl. Some providers also choose to use propofol. Once the sedation is given, you're going to be drawing up your meds. And then you're going to do the prep, which is all sterile, of course, with either betadine versus chlorhexidine. There's a lot of iodine allergies out there, so I prefer chlorhexidine. Some people don't know if they have an iodine allergy, so I always go with chlorhexidine because of that. Angles that we use to line up for the fluoroscope are going to be, you're going to start in your AP. You'll tilt either caudal towards the tail versus cranial towards the head. And then your oblique view, depending on the procedure as well. Next, you'll anesthetize, and then locally, and I tend to anesthetize in the track that the needle is going to go as well for patient comfort. And then you'll advance the needle. Once they're anesthetized, then you're going to confirm your placement with your fluoroscope. You're going to aspirate once you get down to the spot you need to be in, and then you confirm once again that it's not vascular is key as well. And then if there's no allergy, because there's contrast allergies, of course, mainly iodine, you'll be injecting the contrast. And then for epidural type procedures where you do have a risk of vascular uptake, you want to use tubing generally. because sometimes you do want to have live fluoroscopy where you can actually see the flow of the contrast up into the epidural space where the nerves live. Some people also use digital subtraction angiography, or DSA, to also track that. That's an even more in-depth view than the live fluoroscopy. You'll take some additional camera angles just to make sure everything is safe, and then you'll go ahead and inject the medication and apply a sterile dressing. And then post-injection monitoring, generally the first 24 hours to 48 hours, they might have some numbness in their legs, especially if it is an epidural procedure, because you are getting some anesthetic around that nerve root. And then 2 to 4 weeks following the procedure, so it can take up to 2 weeks sometimes for the steroid to fully absorb. So I typically don't see people back in the office after these any earlier than 2 weeks. Kind of 2 to 4 week time frame is typically where I see people back, and at that point the injection should have taken full effect and we can reassess at that point. So materials, we talked about fluoroscopy. So again, radiation safety is important. The key here is that getting a fluoroscopic procedure exposes a patient to as much as 250 to 3,500 chest x-rays, one single procedure. So you want to be diligent in your exposure here, not only to yourself, the staff, but also the patients. So a little bit of history here. So the first epidural steroid injection, first documented case was back in 1901, and the first approach that was used is the caudal approach, and it was used with a local anesthetic at the time known as cocaine. So that certainly has progressed over time. We don't use that anymore. So now, so in the 1920s, they started using some saline and local anesthetics such as lidocaine and bupivacaine. And then 1952 was the first record of corticosteroid injection by Robici. Some epidemiology. So spinal stenosis is a growing problem as our aging population continues to grow, especially with the baby boomers, et cetera. So incidence 8 to 11% of the total population. Between 97 and 2006, you can see that increased quite a bit for those of us over 65. The U.S. population increased as well, so consequently, epidural procedures increased 121%, and has cost quite a bit of money in that time frame as well. So just some anatomy. So as far as the epidural space goes, the anterior portion is the PLL, or the posterior longitudinal ligament. Posterior is going to be your ligamentum flavum and lamina. Laterally, you'll have the pedicles and your foramen. As far as the foramen boundaries, anteriorly you have the discs, the vertebral bodies, and posteriorly you have the facet joints, the fascia, psoas muscles, and inferiorly the pedicles. Vascular anatomy, so stemming from your aorta, you have your 31 segmental arteries, your radicular arteries, and then the ones you want to be careful of are the radiculomedullary arteries, which are the ones that you can inject steroid into and cause complications, like I mentioned, with the non-soluble steroids, such as spinal cord infarct, stroke, etc. So you have your 2 posterior spinal arteries and then 1 single anterior spinal artery, which stems from the radiculomedullary artery. Largest one of the radiculomedullary arteries is the artery of Adamkiewicz, so certainly above the L2 area, or T9, between T9 and L2 is where that lives, and most people on the left side, so that's the one you want to be most careful of. And so here's some pictures, so we can all visualize these procedures. So transforaminally, our goal is to get, this is a lateral view on the fluoroscope, and you can see the needle right there at L4-5 going right into the foramen, which is our goal with the transforaminal approach. This is an oblique view, so we know our goal here with the oblique view is usually where we start the procedure. We're aiming for right under the pedicle in the supraneural approach, which is this approach, and then this is the infraneural approach. You can do it either way depending on which nerve root you're trying to get flow to. So with supraneural, this is L4-5, you're trying to get the L4 flow this way, or you can do it up at L3 through an infraneural approach, which will bathe the L4 level infraneurally. This is what the contrast flow pattern looks like in the AP view, and that's what you want, that nice black contrast flow pattern going into the epidural space there where the nerves live. So there's a cervical, same kind of deal with this one. You can see the flow going up into the epidural space there on the right side, and then you can see that nice contrast flow hitting multiple levels going up and down into the epidural space. This is a thoracic view, and same thing here. You can see that flow along the nerve root, and then that is heading again up and into the epidural space. Interlaminar approach, a little bit different. So instead of going through the foramen with this one, you're going posteriorly through the interlaminar window here, and you're making contact essentially with ligamentum flavum. Once that's breached, then you are into the epidural space, and that's where you'll inject your contrast and get a different looking flow pattern, but also designed to direct towards certain nerves. These often flow up and down multiple levels, even more so than the transforaminal approach. So you can see this is a view of L4-5. You can see it going down from L5 to S1, and then even up some into the L3 area as well. So it goes up multiple levels with the interlaminar approach. You can see the needle right here in the interlaminar window. Same thing here and here. And so these are both lumbar views. This is a cervical view. You can see that one, nice flow up and down as well. And this is thoracic in this view. Caudal is the, once again, the oldest form of an epidural injection. So this was done, blindly essentially before we had fluoroscopy. What you do is you feel for the sacral cornu, and the needle would go right up through the sacral hiatus, and essentially you can see you can get good flow really up to multiple levels with this one as well. This one's looking like all the way up to L4 up here, and even up to L3. So it can go quite a distance with this approach as well. You can see same thing here in the lateral view. Facet joint injections. So again, totally different procedure designed for axial back pain rather than radicular like the epidurals. So as far as cervical goes, what you'll see in your patients, typically axial pain can refer into the trapezius areas as well as periscapular areas. A lot of people complain of headaches, especially occipital type headaches, which sort of radiate up into the scalp area, almost like a ram's horn. We call it, they can have myofascial pain as well associated with it. Same thing thoracic, again, non-radicular, so it's not going to be radiating around to the front of the chest wall or anything like that where a thoracic radiculopathy would. It's typically purely axial. Lumbar, again, above the waistline. It can refer occasionally to the anterior thighs. All these maneuvers, all the facet joints are aggravated typically with extension maneuvers and rotation. So that's called facet loading. So a good physical exam maneuver for that is you take the patient's shoulder and you rotate it back as far as you can to load the lumbar facet joints. Cervical, you're doing the same thing. You're just pushing the head back and twisting it. Thoracic, similar to the lumbar. Some anatomy. So the facet joint is composed of the SAP, or the superior articular process, of the vertebrae below, and the inferior articular process of the vertebrae above. In between is the joint. In front of it is the disc, so it's going to be posterior to all that, and spinal cord and nerves, etc. These are intra-articular facet joint injections, so you can see good flow within the facet joint space at these levels between the SAP and the inferior articular process, as I mentioned. So this is lumbar, cervical, a little bit different. Cervical, the facet joints lie between the articular pillars. So this is articular pillar C5, and this is C4. And you can see that contrast flow in between. Same, you can see it even better in this view on the right here. So medial branch blocks are also procedures directed towards the facet joints. A little bit different. So instead of going into the facet joint, these are designed to go outside of it. So these nerves, which are medial branches, innervate the facet joints. So the idea with the blocks are they're diagnostic procedures. So you're only using anesthetic to block those nerves to prove that's the source of the patient's pain. If that's the case, so it's going to last, short term, the life of the anesthetic. I usually use bupivacaine for these because the half-life is generally longer, about 8 hours. It gives you a broader view rather than lidocaine, which is 2 to 3 hours, somewhere in that time frame. So with the bupivacaine, if they get, we try to strive for about 80% relief in the axial pain for 8 hours or so, and that's a good diagnostic block. It would be shorter, obviously, with lidocaine, as I mentioned. You have to do 2 of these for insurance purposes to prove as a diagnostic procedure that these are where the pain is coming from. Then that will allow you to move on to what's called a radiofrequency ablation, where you go in and actually burn those medial branches, deaden the pain, and hopefully the patient is a lot better after that because you've diagnosed their pain from the medial branch blocks. And ideally, if you get a good diagnostic block, you're going to have a successful ablation. So the medial branches, as far as the anatomy goes, so again, they're extra-articular, so you're going at the junction, basically, of the transverse process and the superior articular process right here. It's called the mammillary accessory ligament. So you can see the contrast flow patterns at each of those sites. In the cervical, so that's lumbar. In the cervical, your medial branches live on the articular pillars, basically at the waist of them, and that's where your targets are for those. Thoracic, you're looking at the superior lateral portion of the transverse process, which basically joins with the nerve, or the rib. So at that point is where the medial branch is located in the thoracic. As I mentioned, radiofrequency ablation. So the difference with this is once you've proved you've got your diagnostic block, you're going in there and deadening those nerves. So you're basically heating them up. So you attach these probes to the needles, and you heat up the medial branches for 90 seconds at 80 degrees Celsius. And the idea here is, again, we deaden those nerves. They do grow back, but it takes a good 6 to 12 months. Doesn't mean the pain's going to come back in that time frame. Some people, it lasts years. Everyone's kind of different, but you can do 2 radiofrequency ablations per year if they do grow back within that time frame. Sacroiliac joint injection. So again, non-radicular buttock pain, not explained by gluteal tendinopathy or piriformis syndrome. You'll have pain with SI joint provocative maneuvers, which I'll show you some of those shortly, as well as transitional movements. So getting out of bed, getting in and out of the car, going up steps, those kind of things tend to propagate SI joint pain. You often see it with pregnancy, of course, as well, especially with the release of hormones, which kind of loosens up the joint, as well as spondyloarthropathies, such as ankylosing spondylitis, psoriatic arthritis, etc. Here's some of those provocative maneuvers. So this is SI joint distraction, thigh thrust, SI joint compression, Faber. So this is the same maneuver used for the hip, except you're reproducing buttock pain rather than groin pain. And then Gainsland's maneuver as well. So if you do get 3 of these that are positive, that's technically a sign that this is SI joint pain, and that's the procedure you should choose going forward. So here's some of the injectate here, going up and into the SI joint on the left. Same thing on the right. This is a lateral view as well. So that SI joint, meets right where the pelvis meets the sacrum, essentially, or the hip meets the sacrum. Innervation of the SI joint is by the L4 and L5, or L4 medial branch, L5 dorsal ramus, and then the S1 through 3 lateral branches. And then, we used to do this procedure more often. Unfortunately, most insurance is not covering it anymore, but essentially it was doing lateral branch blocks similar to medial branch blocks to get a diagnostic block and prove that's where their pain is coming from, and then go in and ablate those nerves, very similar to the RFA for the lumbar medial branches. So complications, most common complications, infection, pretty small risk, but it's there, okay? So 0.1%, so it's not 0, but pretty low risk of all overall. Most common pathogens are your skin flora. You can cause abscess, discitis, meningitis, osteomyelitis. Usually it's using poor sterile technique, so it's pretty rare, but it can happen. Or you can even puncture the intestinal cavity and cause seepage of microorganisms from there, which can lead to infection as well. Epidural hematoma, pretty rare as well, 1 in 150,000. Usually that's an interlaminar approach, and if you've not taken a patient off blood thinner or something like that, risk certainly goes up with that, but usually take patients off for 3 days or more depending on the agent, and usually you won't have any problem with that. IV injection basically could lead to decreased efficacy, disorientation, dizziness, tinnitus, twitching, metallic taste. That's from the lidocaine. And major symptoms could include seizures, unconsciousness, coma. Intravascular injection we talked about with a particulate steroid, which can lead to a spinal cord infarction or CVA, depending on if it's in the lumbar, thoracic, or cervical region. Other complications, so hyperglycemia, of course, from corticosteroids. So you'll get a mean increase in blood glucose level 125. So you're diabetics, you want to be very careful. I typically won't inject anyone with a hemoglobin A1C over 9. That's kind of my cutoff. That's my hard cutoff. 8 is kind of borderline. We usually check a sugar too, blood glucose level, finger stick before the procedure as well to make sure it isn't too high. You'll get allergic or hypersensitivity reactions depending on if that's contrast, iodine, etc. Spinal cord infarct we discussed. Dural puncture with an interlaminar approach is also a major risk. If you go too far in the interlaminar space, that can lead to a spinal headache and respiratory depression in rare cases as well. And then other complications, urinary retention, not very often, but it is a complication. Disc entry is pretty rare. Air embolism with interlaminar approach as well. And then, of course, the steroid side effects, pretty common. You see these dizziness, headaches, flushing, etc. Gastritis, insomnia can last a few days as well. Prolonged exposure can also suppress your hypothalamic pituitary axis and ACTH. Absolute contraindication. So if someone has a bleeding disorder, typically I wouldn't inject them if they have a platelet count less than 70,000. So we would want to get that lab prior to the procedure. Pregnancy, of course, with fluoroscopy. Don't want to x-ray or provide any radiation to the fetus. Infection, as of course, corticosteroid increases risk for infection and can worsen an infection already present. CHF, if you fluid overload them. Diabetes, again, a relative contraindication depending on their A1C. And then positioning, if they can't, for whatever reason, tolerate being on their stomach for a short amount of time, that's, again, a relative contraindication. That's it. Questions? Okay, we'll do a couple. Yep.
Can you explain a little bit with the nerve conduction and EMG and how you kind of use that to determine their value? I've heard EMGs aren't as relevant as they used to be, but you said you did them, so just kind of go into that a little bit. That'd be great.
Yeah, so it depends on what you're looking for, right? So if you're looking for to sort out like a peripheral etiology of a nerve injury such as carpal tunnel syndrome, cubital tunnel syndrome versus cervical radiculopathy, it's pretty useful in that sense because you can easily tease those out. Certainly you can get advanced imaging like an MRI, and I wouldn't do any of these procedures without an MRI, by the way, as well. But that will sort of correlate with the EMG. So if you see that they have a disc herniation at C5 and C6, C5, C6, and the C6 nerve is being affected on the EMG, and they have no carpal tunnel syndrome to complicate things, then that's pretty clear cut that that's where the source is coming from. So it's purely a diagnostic procedure, but a lot of times used to sort out different etiologies of where the pain is coming from. Okay. Anything else? Got time for a couple more?
I got one more.
Yeah.
Why does the contrast or whatever go up instead of down?
So it depends where you're doing it. So the interlaminar ones will tend to, for an epidural injection, will go up a couple levels and down, okay? If you're doing transforaminal approach, if you go supraneural, so above the nerve, it'll go to the nerve root above. So if you're at the L4-5 level, it'll go to the L4 nerve. But you can also do an infraneural approach with that, which will get it at L3, which will get it to the L4 level infraneurally. So it depends how the position is of the needle and where you want it to go for your target.
So you mentioned that these are kind of in between medical management and full-on surgery.
Yeah.
How long do you like to give medical management? How long should I be doing that before I am referring someone over?
Yeah, so usually 6 weeks of conservative care is what's recommended, similar to a surgery. So that includes physical therapy for 6 weeks and chiropractic, et cetera, medication management. So at that point, if they're not making any progress, then it's time to send them over. Certainly if they're regressing within a few weeks or you see a significant decline, send them sooner. But you at least want to attempt any sort of conservative care before you jump right to the injection, generally.
Here's your comment about thoracic spine. You said if it was radicular, you wouldn't consider the epidural?
No, you would. So if it's radicular, if it's coming across the chest wall area where the thoracic nerves tend to radiate, then you definitely want to consider epidural injection. If it's non-radicular, that's when you direct or think about facet joints more so as the pain mediator. Okay. All right, guys. Thank you for your time.